I'm actually a neurologist with interest in the bladder, bowel, and sexual dysfunction. And I come from the National Hospital for Neurological, Queen Square in London. Many thanks, Doreen, for organizing such a meeting. Just to get an idea about people in the room, so how many of you are physiotherapists? Nurses? Doctors? Urologists? And are you urologists as well? What's your background, sir?
Rehab.
Rehab, okay. Just to know how to pitch the talk. So I was a bit, I was pleasantly surprised when Doreen emailed asking if I could speak, and I was wondering for a workshop with a title like this, what's the role of understanding the neural control and what happens in health and disease? But it became quite clear that actually, if we want someone to be supported to manage their bladder back home or in the community or home-based, actually, we need understanding about the lower urinary tract dysfunction in that patient and make sure that it's actually safe for that patient to be managed in such a program. And so the next 15-20 minutes, I'll be taking you through briefly about what happens in bladder control and health and what happens following disease. Now, I don't have a disclosure slide, but I'll just say that there's no conflicts of interest that are relevant to this talk, and that I've come out to Montreal I was self-supported. So carrying on. Now, as compared to other sort of autonomic visceral systems, such as say the cardiovascular system, the lower urinary tract is unique. And this is because of several reasons. Importantly, the dependence on the central nervous system, the fact that there's, because of which there's an element of voluntary control of the lower urinary tract, which is not there for, say, the cardiovascular system. The functions of the lower urinary tract are essentially dependent on learned behaviors that you'll be hearing about later on. And also, if you look at it from a neurobiological perspective, the neurocircuitry, as compared to, say, the tonic activity that sort of modulates and regulates the blood vessel tone and the heart rate, for example. Here it's a phasic activity of sort of storage, voiding, storage, and voiding. And I won't be taking you through too much about the innervation of the lower urinary tract, except to say that, as you're all aware, there are two sets of nerves that supply that innervate the lower urinary tract. You have the autonomic nerves, which you have in blue, the sympathetic, which rise from the T9 to L1, T11 to L1 levels. And then you have the parasympathetic, which are from the sacral 2, 3, and 4. And the second set of nerves are the somatic nerves that emerge from the similar S2, 3, 4 nerves. And at the level of the bladder, of course, they innervate different parts of the lower urinary tract and they have different receptors at the nerve endings. So the parasympathetic essentially innervates the bladder, and the free nerve endings end on the muscarinic receptors, the M3 and the M2 receptors. Releasing acetylcholine activates the muscarinic receptor, resulting in tracer contraction. Whereas the sympathetic free nerve endings release noradrenaline, and at the level of the bladder outlet and the internal urethral sphincter, especially in the male, it activates the alpha-1 receptor, and which results in the contraction of the urethral sphincter. The same nerve endings also do have branches to the bladder, and they end on the beta-3 receptors. And you're aware about the recent introduction of drugs, the beta-3 receptor agonists, and that's the basis of which. And of course, the one in yellow is the somatic system, which is under your voluntary control. Essentially, the free nerve endings release acetylcholine that activates not the muscarinic receptor, but the nicotinic receptor. So it's a different receptor, resulting in contraction of the external urethral sphincter. Now, moving on, at the level of the spinal cord, there are numerous reflexes that are involved in sort of the spinal control of the lower urinary tract, which is essential in health. I won't be going through too much of these, except to say that there are both storage as well as voiding reflexes that are spinally mediated. So what happens is that there's an afferent volley of signals from the bladder As we speak, that cup of tea or coffee that you've had is slowly percolating through your system, reaching your kidneys and being filtered and filling your bladder. And at some stage during the course of this workshop, you probably will start feeling your first sensation and a normal desire and a strong desire. And it's probably between the normal desire and strong desire that you start asking yourself questions. How full is my bladder? And is this the right time and the right place to void? So now it's really about what's the basis for those questions. So and this, of course, doesn't happen in an infant. And the reason being is that infants essentially have a sacral cord, a spinally mediated nutrition reflex. And what happens is that during development, there's the emergence of supraspinal control over the sacral mediated nutrition reflex. And it's this emergence of central reflexes that makes the control of the lower urinary tract in an infant different from that of an adult. And if there's any sort of developmental delay, or if there's any damage, either congenital or in the newborn, what happens is these reflexes do not form. Now, at the level of the brainstem, the structure that's quite important for initiating voiding is the Pontine Nutrition Center, the Barrington's nucleus. Initially, it was known that there was such a center, and this is based on ablation studies in cats in the early 20th century, and subsequently it's been proven, shown later on. But now in the era of functional imaging studies, you imagine how difficult it is to actually pee inside of an MRI scanner or when having a PET imaging. So it's not very easy to actually demonstrate the Pontine Nutrition Center. But in the few studies where healthy controls have actually voided inside the scanner, it's been demonstrated that the area corresponding to the Pontine Nutrition Center activates. So what we know is that similar to in subprimate animals, that in humans also there's a Pontine Nutrition Center that becomes activated for voiding. So essentially, if you look at lower urinary tract control in a nutshell, essentially two neural programs and a switch. And if you think of the two neural programs, you have a storage phase and a voiding phase. And if you think about it, there are two players in these programs. You have the detrusor muscle and the sphincter muscle. And in 99% of your lifetime, if you're a healthy control, your bladder will be in the storage phase. And it's the 1% of the time when there's a switch to the voiding phase when one voids. And in the storage phase, the detrusor muscle is relaxed and the sphincter muscles are active and contracted, and this is what keeps the individual dry. Whereas in the voiding phase, it's the converse, the detrusor muscle is active and actively contracting to eliminate urine. The sphincter muscle is relaxed and therefore the urine can bleed out and the person voids. And the switch between the storage and the voiding phase is essentially various brainstem structures, importantly the Pontine Nutrition Center, but also the periaqueductal gray, which is a structure just above the pons in the midbrain. So essentially what happens is with that, and all of us, what's happening now, hopefully, is that we're in a storage phase. And there's afferent signals that ascend up the spinal cord. And the first point of relay of these afferent signals are at the level of the periaqueductal gray. And there's subsequently activation of other parts of the brain, especially the insula and the anterior cingulate cortex. And the medial prefrontal cortex is quite important in this. And it's sort of the area of the brain that is sort of the decision maker. Not only for the bladder, but for any sort of cognitive task, especially if it has an emotional flavor to it. And so in health, hopefully in all of us, the medial prefrontal cortex is inhibiting the PAG, as we said here and hear this talk. And therefore there's an inhibition on the Pontine Nutrition Center, because of which the bladder is your continent. What happens in voiding is the safety switch from the hypothalamus is no longer there, it's activating the PAG. Those inhibitory signals from the prefrontal cortex are now facilitatory. So the PAG, rather than inhibiting the PMC, is now activating the Pontine Nutrition Center. The switch is now on, and what happens next is that there are now facilitatory signals going down the spinal cord. The pelvic floor muscles and the sphincter muscles relax, the detrusor muscle contracts, and lo and behold, the person voids. And this is what happens in health. So understanding the physiology will now bring us to the pathology, what happens following neurological disease. And so essentially you have lesions that are suprapontine and lesions that are infrapontine, which can be either spinal cord or even below the spinal cord, affecting the sacral, the sacral cord or infrasacrally. Now you're familiar with all the neurological conditions. However, it is important just to remind oneself about these conditions, because the patient that you're considering for a home-based treatment might have Parkinson's disease, for example, and it might be someone with a suprapontine pathology, which later on you'll realize is actually having a different pattern of lower urinary tract dysfunction as compared to, say, an individual, say, multiple sclerosis that you're seeing, where there's, in addition to suprapontine lesions, there are spinal lesions as well, and thereby producing a different pattern of lower urinary tract dysfunction, and also a different risk for upper tract damage and renal failure. And sacral and infrasacral lesions, where it's a different pattern altogether. So what happens in a lesion of the suprapontine, which is a stroke, Parkinson's disease, essentially it's an uninhibited detrusor muscle, and urodynamics will show detrusor overactivity. And because of the neural programs that I mentioned earlier are intact, there's a synergetic contraction between the detrusor and the urethral sphincter muscles. Now, what happens following spinal cord injury is that in health, there's the sensory limb of the sacral nutrition reflexes through the A delta fibers. What happens is following spinal cord injury is a different set of fibers called the C fibers that drive the overactive bladder, and it just becomes a spinally mediated nutrition reflex, similar to what happens in the infant. And this is what drives lower urinary tract dysfunction in patients with spinal injury and detrusor overactivity. So what results is involuntary bladder contractions, a small capacity, and also incomplete bladder emptying. What also happens is something called detrusor sphincter dyssynergia. So that synergic contraction that I told you about is no longer there, but rather the detrusor muscle is contracting, trying to eliminate urine. The sphincter muscle is not relaxing. And so they're both co-contracting, and this is what the urodynamic hallmark for someone with a spinal cord injury. Now, what happens when the injury is of the lower end of the spinal cord, what we call the sacral spinal cord, or the chorda equina, or the peripheral nerve, such as diabetes, is that it's rather than, in contrast to the storage dysfunction that you would have you would appreciate before, it's predominantly an acontractile or hypocontractile detrusor muscle. The patient is often in chronic retention and the variable loss of bladder sensation. So you can clearly see that this sort of a patient will be managed entirely different from the patient with, say, Parkinson's disease with a suprapontine pathology. So essentially, based upon that, the three patterns that you see with the suprapontine injury: storage symptoms. Patients, if you scan their bladder, the post-void residue is usually less than 100 mils, and if one were to proceed with urodynamics, what you find is detrusor overactivity. In contrast, if it's an infrapontine suprasacral lesion, you have a mix of storage and voiding symptoms. The post-void residue is usually elevated, and if one were to proceed with urodynamics, it would be detrusor overactivity. In addition, you would find the hallmark of detrusor sphincter dyssynergia, especially if it were a video urodynamic study. And if it's a sacral infrasacral lesion, in contrast to the above, predominantly voiding symptoms, that when you investigate, the post-void residue is usually high, and often what you find urodynamics is an acontractile detrusor muscle. Now, you're aware, all of you in the room are aware about the common causes for incontinence, which I don't really need to take you through. But you must remember, and of course you would also be aware, that there is functional incontinence, which is an element that's probably unique for patients with neurological disease, and that the patients might have an element of urge, maybe urgency, which in the normal course of things, the patient would have been able to maybe reach a toilet on time and not become incontinent. However, what happens is because of problems with mobility, for example, a patient with Parkinson's disease, or maybe with multiple sclerosis, quite severe spasticity and weakness, is that then the mobility slows the patient down, and the patient who just has an urge on their way to the toilet becomes urgent, and then they become incontinent. And this is something that needs to be borne in mind, especially when you are sending the patient home with a plan, because if you do feel that it is an issue of mobility, the patient should have made it on time, and maybe if that were intervened and there would be less episodes of incontinence, then it might be actually speaking to colleagues who are maybe focused on maybe the neuromuscular side of things, or maybe even to the consultant, maybe the neurologist, and saying, well, you know, could you do something more about the mobility? The other practical issue that you'll be aware about is toilet access. And in many countries, the sole toilet in the house is on the first floor. The patient resides on the ground floor most of the daytime. So by the time the patient treks up those flight of steps and reaches the toilet, the patient might become incontinent, in which case the intervention is not an antimuscarinic, but rather is perhaps thinking of either a portable commode downstairs or changes, alterations in the house so that there is toilet access downstairs. What's relevant in neurological patients with cognitive impairment is that there's quite complex cognitive dysfunction that happens. So sometimes patients can have visual spatial disorientation. So you and I know that that's the exit. So if we did need to go to the toilet, we would just make our way out and go. A patient who has disorientation visual spatially doesn't recognize that that is the exit. The patient becomes lost and confused in their own bedroom and then becomes incontinent because they just couldn't find the right, they couldn't recognize that this is the door for the toilet. Sometimes patients with a stroke, for example, or other neurodegenerative conditions or even demyelinating conditions have problems with speech, so they can't communicate their toilet needs, or perhaps do not understand their toilet needs or what they should be doing in case they do need to visit the toilet. Sometimes there might be issues with memory, in which case it might mean spending more time with the patient or developing other sort of cues for the patient for them to recognize what to in case of the need for the toilet. And sometimes there can be complex behavioral changes, compulsive behaviors, or social disinhibition, which can supervene. Quite a few patients have apraxias where they're unable to perform a complex motor task, such as unzipping themselves, in which case the intervention is more to do with sort of changes in the clothing to make it simple for them to undress when they need to visit the toilet. Now, I think it's quite important that we recognize the risk for upper urinary tract damage, and because not all neurogenic bladders are the same. We do tend to assume that all patients with a neurological disease have a higher risk for renal failure or upper tract damage, in which case we must be cautious. But there are differences between these. For example, if you look at multiple sclerosis, the prevalence of upper tract adaptation is only 8%, as compared to spinal cord injury, which is nearly 3 times that figure, and spina bifida, which comes to more than 8 times that figure. And then there was a neuroepidemiological study in the UK a few years ago where they looked at the data of people that were going into renal failure. So it was a population-based study, but what they showed was individuals with spina bifida had an 8 times increased risk for developing renal failure as compared to the general population. Whereas for patients with spinal cord injury, it was a 5 times the risk. And for multiple sclerosis, it was exactly the same for the general population. Which means that if you have a patient with spina bifida, you don't really want to be keeping them at home and saying, well, this is fine, manage conservatively, because actually they need to be monitored much more rigorously as compared to, say, someone with, say, Parkinson's disease or even multiple sclerosis. There isn't, it's not clear why there's a difference. However, the general rule of thumb is that patients with a progressive neurological condition, their risk for renal impairment or upper tract damage is less as compared to individuals with a static condition, say, for example, a spinal cord injury, which has happened and the patient suffers from the consequences from what happened at that one particular event, or spina bifida, which would have happened in utero. And lastly, it is worth remembering that patients with neurological disease do not have just problems with their bladders, but they have numerous other problems as well. And the bladder is one amongst them, and it is quite a prominent problem. But it does also mean that our approach to a patient with, say, a neurological disease with incontinence will be slightly different. And we do need to maintain, make sure the upper tracts are preserved. We do need to make sure that the risk for urinary tract infections are minimized. We need to try to attain continence. But expectations of patients with neurological disease are often different from the expectations of someone, say, with an idiopathic OAB, where their sole complaint is that of incontinence. And this must be borne in mind when we start kind of putting together treatment goals for the patient. So this is really the concluding slide. And essentially, I've taken you through the neural control of the bladder and health. I've explained to you why a lesion at some part of the neuroaxis can result in various patterns of lower urinary tract dysfunction, and one size doesn't fit all. Suprapontine lesions usually don't cause problems with incomplete bladder emptying, whereas spinal lesions often do. Thank you.